Chris Master here with the next video in the hypertension series. So hypertensive emergencies and urgencies. A reminder that below this video there are links to the two articles in reference here at the end, two useful PDFs to have a look at. So the first one we're going to do is hypertensive emergencies, and the importance here is you're thinking worst case scenario, you want to rule this out. If you've ruled that out, you probably have a situation of hypertensive urgencies. And in this part, we're going to have a look at the need for therapy. Why do we need therapy? The agent you're going to choose, the timeline, and important goals in terms of blood pressure numbers, and then what are the dangers in treating these patients. So this is an American College of Cardiology definition. The blood pressures do not need to be that high. I think the emphasis should be a patient with a high blood pressure with acute end organ damage. So what are we looking at in this vein? Hypertensive encephalopathy is something you'll probably encounter the most in this scenario. So if the patients have features of this plus an elevated blood pressure, the patient should get intravenous therapy. Intracranial bleed, hypertensive emergency par excellence, you want to bring down the blood pressure to less than 140/90. Then you have your acute coronary syndromes, beta blockers and nitrates is what you should be thinking of. Left ventricular failure, once again we're talking about diuresing these patients and potentially adding on nitrates or SNP, sodium nitroprusside. Acute aortic dissection anytime you know well. Right. So in summary, you're thinking of the brain, you're thinking of the heart, aorta, pregnancy, and an AKI as in what we discussed in the previous video, and that is hypertensive and malignant hypertension. Hard to treat. You want to give these patients intravenous therapy. We'll have a look at the drugs there, and then time. You've got minutes to hours to lower the blood pressure in this scenario. You want to actually just cool things off a bit and get the patient out of danger. You don't want to lower the blood pressure to a particular goal. You want to do this in a monitored setting. The target is 10 to 25%. As I've said, not a particular number. But there are always exceptions, and this one in here in particular is intracranial bleeds. And you want to bring down the blood pressure at least to 140/90 or even less according to the literature. So definitely think about screening these patients for secondary hypertension once everything has been sorted out. Agents to be used. So this is a useful table to pause and have a look at. Look at the onset of action, the half-life. Don't worry about this for the moment. And you want to have a look at what contraindications there are and what side effects you could expect. So here's a neat table looking at the various agents that connect to particular diseases. So according to your end organ damage, you'll choose an agent that fits the profile for treatment. I think the one I'll use here is a good example is acute aortic dissection. Just remember, so this patient's dissecting very, very high blood pressure. If you give a beta blocker, you are reducing the amount of pressure the ventricle mount into the aorta, also called shear stress. Giving a beta blocker reduces the shear stress, and that is the one important modality of treatment. And then ramping it up by using nitroprusside to bring down the blood pressure as well. Right, so you've got a nice ETG table there. Just be wary of hydralazine. It is a drug that doesn't give you necessarily a very reliable blood pressure lowering. So there'll be a difference between patients on how this responds. Even the same patient, individual variation will happen, and it'll lower the blood pressure at one moment, and when you use it again later on, it doesn't do anything. So potentially you could consider flipping those two around. First the beta blocker and then hydralazine, and you may have a more reliable effect. Most certainly all the others are appropriate depending on what end organ damage you're dealing with. So what are the dangers of therapy? Hyperperfusion of the brain. Here's a good slide to have a look at. You'll see that hypertensive patients shift to the right. And if you then start lowering the blood pressure, it's all shifted to the right, and you can induce hypoperfusion. In this particular slide, it's cerebral hypoperfusion. What happens then? You can have watershed infarcts. Hypertensive urgencies, much more common. So we've got our definition there. You don't really have an acute end organ damage, right? So that is the important part to exclude. So now you're dealing with a hypertensive urgency. So there often is an underlying cause, and you should be aiming to look for that and treat. You have at least 24 hours to sort out. So this is where this name is counterintuitive. You do not have to deploy urgent therapy. The goal of blood pressure is to bring down the blood pressure gently. So we don't use parenteral agents. Don't slap on a nitrate patch for a patient that does not have a hypertensive emergency. And we'll have a look at evidence to support that. So this is the slide that you want to work through with a patient, because treating these underlying issues is much more important than hypertensive agents. Right, so what are our options? So you can use all those. The Nifedipine, just be wary, can give you a high rebound blood pressure. So what landmark studies am I talking about? In the last couple of years, actually in the den of COVID-19, these research papers came out. The one thing is, if you intensify therapy in the hospital for a patient that has hypertension, and you think you're doing something good, because that is what we do, we reduce blood pressure to improve outcomes, you in actual fact do not do that, because it's a stressful environment physiologically, and the patient has hypertension related to that. It's only on the outside where you'll know whether this is a true uncontrolled hypertension. And you can see the chances of patients coming back within 30 days increases. So this is a paper from JAMA in 2019. Same journal, a year later, different authors, but the importance here is, if you're too aggressive with your therapy on the wards, you are going to induce bad outcomes, which is acute kidney injury and myocardial ischemia in this paper. Once again, the link for these two articles is down below. Right, so what are we going to do next? The next one will be uncontrolled hypertension and secondary hypertension screening, and what should you be doing in the hospital if your consultant or registrar asks to do a secondary hypertension workup for me, please. Thanks for watching this video. All the best, Chris.